reconstruction can also be done. But mostly it is HTO at that stage. And bone scan is negative, you can still do a PCL reconstruction. If the patient comes with a clear instability, which will happen mostly when there is a associated collateral ligament injury also. If there is a arthrosis, again this patient has gone out of your hand, more or less reaching towards future TKR. If there is no arthrosis, you can reconstruct PCL and whichever collateral ligament is there as well. So issues in reconstructions are these. We can debate inlay, transtibial. I wouldn't go into all those details. These are the issues which, if you want to do a PCL reconstruction, you should read up a little bit about which one do you want. I do all single bundle. I do all more or less arthroscopic, at least in chronic stages. And graft choice, we have very limited. We use hamstring. Some people use patellar tendon. We don't have allografts here. So all these things are of theoretical interest. Basically, in our country, we don't have those facilities available. What are the key points in surgery for anybody who is deciding to do it? Your positioning has to be at the end of the table. You should have access posteromedial, posterolateral, because you make those portals as well. A special instrument, especially a good PCL jig, which you can use very well. Since you don't do this operation every day, you must use the jig which you can very easily use on the table. And ability to make posteromedial portal. And this you should actually try in some of the normal ACLs and meniscus, and don't try it first time on a PCL deficient knee. I think once in a while you should do a posteromedial portal just to see how to make that portal. And that's what you may need in a PCL reconstruction, to see at the back of the knee and also to clear up that area. Tibial tunnel positioning and femoral tunnel positioning is very critical, and I'll come to that. And of course graft passage is also a little bit tricky, because the graft has to go above on the tibia and then take a turn. So it is a little bit difficult at that stage to pull the graft in, because it is not going straight from femur to tibia as it happens in ACL. So it's a little bit tricky to get the graft passage, and you should anticipate these problems and you should know what to do with this. And finally, you should have all the possible tools of fixation for ligament fixation. So above tibial tunnel, that is the position. Your tibial tunnel come at the back of the, not the interpatellar area. It has to go all the way down, and this is where it has to go. Jig, a pulling jig with a stop that you can under vision see that is going through and it can enter the vessel otherwise. So use a proper PCL jig which has that kind of a protection, and keep an eye on that area either through a posteromedial tunnel, or some people do what is called a safety incision. You can put an incision posteromedially here and put a finger and get guided by the finger if you're not too good with your visualization posteromedially, and that's the way you can save injury to the muscles, to the vessels behind. Now, entry point in the femur is also very important, and that's what it should be, about 4 to 5 millimeter beyond the articular cartilage, and not too high, not too low, somewhere there. And these are the wrong positions of these tunnels. So all this one has to understand the day you want to do this. And of course, post-op rehab is required. Again, mobilization in prone lying keeps your reconstructed PCL safe, and you can still regain the movement. And at some stage, a ROM brace can help prevent collateral ligament if you have done them along with PCL. Thank you for your attention.
We have discussion. I invite Dr. Joshi and Dr. Maheshwari and Dr. Pranjal. Please, questions from the house.
My question is to Dr. Maheshwari. The patients who satisfy your conservative criteria for PCL, those patients at times have felt in follow-ups, they're complaining of difficulty in squatting, that is flexion beyond 100 degrees or so. Your take on that?
Yeah, they do have a little limitation of flexion. I think it's because of a lot of fibrosis happening in that area, and there are a lot of associated injury, maybe to the posterior capsule. And I see this more when there is a avulsion injury, and they have a limitation in complete flexion. I don't think I can do anything about it. I just leave them as it is.
Dr. Pranjal, you want to say
anything you do? Pranjal?
Yeah, I have also noticed the same. I think most of these are single bundle reconstructions that we are doing. Possibly they are not absolutely anatomical because we have huge.
He's talking about conservatively treated PCL. They have limitation in flexion.
Oh, conservative. No, I was talking about surgical. Sorry, I have not come across something like that.
No, you want to comment on this? The conservatively treated PCL, there is lack of full flexion. What will you do? This is the question.
In an isolated PCL injury, I would rather rehabilitate them. I've rarely come across someone who has not regained their full range of motion in an isolated PCL injury treated conservatively.
I think logically they will have restriction of terminal flexion because the tibia has sagged posteriorly. So whatever conservative treatment you do, the tibia is going to sag posteriorly when they go into deep flexion. So you have to just tell them to avoid doing that. I think there is no way by which you can put them on a quad exercise program, but I think you cannot totally avoid the posterior sag.
Actually, there are two types of patients. Passively you can do full flexion, but actively they don't do because it's painful. That is the initial stage, because as Dr. Maheshwari told, there is patellofemoral tightness because of the posterior sag of the tibia. So that surface gets tightened and then there is anterior pain in those patients. So they avoid that. The second is they get sort of permanent stiffness. Even you can't do actively or passively. So in those cases, I think you can't do anything. In first case, like if you are able to do it, but it's painful and the posterior sag, I think you should reconstruct the PCL.
But in those patients, conservatively, like very minimal avulsion of the posterior tibial spine, and they have healed even in the MRI and X-ray, they also complain the same phenomena.
Yeah, I've seen this more with people with avulsion injuries. Because I think a lot of callus forms in that area, capsule flexion, and sometimes extension. I think that can be managed with the stretching, but they continue to have last 10 degree of flexion not possible, which has to be accepted. You can't do anything about it.
Sir, what is your rehabilitation protocol in a case of reconstructed ACL?
Reconstructed ACL? What's your rehab?
Rehabilitation protocol.
Normal ACL reconstruction.
The normal ACL reconstruction, they are in, I keep them overnight for two nights at least in the clinic. They have a rigid knee brace which is used for 3 weeks while walking and sleeping. They start opening the brace from the second day onwards, doing passive range of motion starting from 5 degrees and increasing by 5 degrees every day so that they have 30, 60, 90 degrees range of motion by the end of 3 weeks. They start walking with crutches or a walker from the second day, non-weight bearing for the first 2 days, followed by partial weight bearing. And in the next 10 to 15 days, they are allowed to bear weight completely. They can start actual static quads from the second or third day and isometric hamstrings from the end of 7 days when they have 30 degrees range of motion. Once the 3-week period is over and the rigid knee brace is out, then we give them a hinge knee brace which is used exclusively outdoors, now not indoors. And then they go on a closed chain kinetic exercise program like doing leg presses, half squats, but they do not do open kinetic chain exercises for about at least 6 to 8 weeks. So that is the normal protocol. They can resume sedentary activities like going to office and work in 3 to 4 weeks, and sporting activities like straight line jogging only after 4 to 6 months, and contact sports not before 9 months to a year.
Thank you, sir. Dr. Maheshwari, in an acute PCL grade 3 combined injury, as you mentioned, the treatment of choice is operative. So will that be in the acute setting, or you do the collaterals first and then do the PCL reconstruction later?
So this is about 7 to 10 days, but I do both together because I think it's all more or less open surgery. More or less open surgery, because there is a God-given plane. So if it is a collateral injury with PCL injury, it is God-given plane. I'm not doing any additional injury. Just cut the skin and you have everything in front of you.
You will not do the PCL arthroscopic reconstruction?
No, there's no need because it is all open, number one, and I can't do arthroscopic. With such a massive collateral injury, to build up the pressure inside and to see everything arthroscopic is not possible for me. And it is not required actually, because everything is actually open. If you have an MCL injury going all the way posteromedial, PCL also gone, you just make the skin incision and just put a valgus and everything is visible to you. In fact, what I cannot see is the femoral attachment of PCL.
Yeah.
So first thing I do is quickly do my arthroscopy diagnostic, which is very bloody because there is no distension there. And then I make a tunnel in the femur, because that is something I cannot do from that incision, from open medial side. And then I go back and make a skin incision on the medial side, for example. Everything is open there. And I can see the whole upper tibia just by putting some valgus stress. And I can actually do the PCL tibial tunnel under vision, more or less under vision with my jigs, but I can actually see it, put my finger there, and then manage PCL reconstruction. So it's more or less open surgery for me at that time. And if you fix them well, everything, repair them well, you can mobilize them as soon as you can by any other method. So I do both combined.
And secondly, if it's an ACL with a grade 3 MCL, what would be your take on that? Acute ACL with a grade 3 MCL.
Okay, so I have become a little bit aggressive about MCL lately. Two considerations. One is if it is a grade 3 MCL and the patient is a sports person or an active person, which I don't find many.
Not a sportsman.
In my practice, it is all you and me types. I do ACL say about 10 days to 2 weeks later. And that time I realize if the patient is active and particularly if he has a valgus knee. So my decision to repair a grade 3 MCL with ACL depends on activity level of the person and also alignment of the knee. I look at the other side knee. If the other side knee is valgus, I'm more aggressive about MCL reconstruction. If it is not valgus or it is varus, I'm a little bit less invasive about MCL repair. I treat it conservatively in a brace later on. With ACL, conservative MCL. So I'm a little bit, it's not 100%, but if the alignment is valgus, if the patient is active sports person, grade 3 MCL tear, these days I tend to fix them or repair them when I'm doing ACL as well.
But generally, weekend sportsman, weekend warrior types of.
Weekend warrior, if it is a normal alignment, you can treat it conservatively after doing the ACL.
Thank you.
So I don't do what a lot of people do is they do MCL first, they treat them in a brace, let the MCL heal, 6 weeks later go in and do a ACL. That's what a lot of people do. I think it is a double rehabilitation for the patient, long rehabilitation, and I don't find with currently available techniques of mobilization, I can mobilize them after ACL as if there was no MCL. So I just mobilize them more or less immediately. You would like to give a comment?
Yeah, maybe I have a little difference of opinion over there. Like I said, the decision depends on a lot of factors. The age, activity, what you feel, the compliance with rehabilitation.
Pranjal, please be precise.
Yeah,
Very
so
quick
if there
and
is the
precise.
extent of injury, if you're saying it is a grade 3, usually you have a posteromedial complex injury where you need a large amount of repair that is required. When you're doing those kind of repairs, and you add an ACL reconstruction onto that, the rehab becomes very difficult. Very often these patients become stiff. So unless the patient is really very active and a sports person, we can do both at the same sitting. But otherwise, I would prefer to do it as two-stage procedures. And very often we've seen that after we've done medial complex repair, these instability. And if they don't have an instability, very often you do without doing an ACL reconstruction. These patients, they don't follow up very often.
Yeah. And question, please.
Question and a comment to the panel, please. This is regarding your talk about the H2O, which may be required in a conservatively treated PCL, which comes late. I just want to make a comment. A short segment X-ray, just a knee AP X-ray of the varus, really reveals the true extent of varus. The second thing is about a PCL injury is when you want to do an HTO, you want to try and increase the tibial slope. And what we recommend in a medial opening wedge is that you do not alter the tibial slope by ensuring that the posterior part of the osteotomy at the posterior corner opens up more than the anterior part, which is about 60% to 100%. But if you want to increase the slope, you just make your osteotomy not the tibial slope and that you open them parallelly. In the same manner for ACL, you do a closing wedge osteotomy ideally, or any other osteotomy in which you use the slope. You create which stabilizes a chronic ACL. This, of course, most of us know, but my question to the panel, please, is as in Noy's work, he found for some various reasons, there is a ligamentous injury which is not repaired. He found a group of patients, he did intense rehab after the HTO, and they never found the need for an ACL. What is your take on this, please? Anand, please.
Yeah, I think we have instances where we have done a high tibial osteotomy and we didn't have the need for an ACL reconstruction. We have quite a few examples of these. When patients come very late, they already have a varus with secondary posterolateral laxity, a varus thrust when they are walking. I think our first thing is to get the alignment right and do away with the lateral thrust, because that's going to destroy our ACL. Second stage, we would only if the patient has complaints of anterior instability. But otherwise, I think the osteotomy is the treatment of choice for these neglected ACLs, PCLs.
So how late is neglected in your lexicon?
Sorry?
How late is neglected? How late when they come?
No, I think it all depends on, suppose I have a physiological varus to begin with, and I have an ACL deficient knee, and I am a high level or a high activity person, I am going to land up with my physiological varus will soon progress into pathological, leading to a lateral thrust. But if I have a varus and an ACL deficient knee, but I immediately control my activities, and we have had patients who have been managed for 25 years without an ACL reconstruction. But then you have to really modify your lifestyle. You cannot do high impact sports, you need to do low activities, non-loading activities. Find people you will from physiological.
Your question, and this is often made, that doesn't mean that patient is right.
Okay.
Actually, more often than not, patients get fed up with the whatever. Once they go through 3 months of torture, then they learn to accept what they have, and they learn about it.
Now, what is the scientific way? Let's take out the emotions.
So scientific way is whatever patient expects. If patient decides after one surgery to accept a low-key activity, and if he's fine, he's fine. I don't operate on him.
But after 3 years, he will spoil his knee, and then he will say, you were the expert.
I'm sorry, he may not. If he's low-key activity, he may not do anything. Yeah.
I've seen those patients which we have repaired the posterior medial corner properly, like what Pranjal said, and they need to be immobilized initially in flexion, because it is mainly the posterior medial corner which is a secondary constraint to anterior translation. And not the patient has come arthroscopy 18 years ago, and then we did everything in the posterior medial corner, all structures. Believe me, I followed this patient up till the time she got married, till about almost 7-8 years ago. She had I could not demonstrate anterior instability. The ACL was not there. I have seen it. It is not there. I have done arthroscopic lateral mastectomy, same stage, open with posterior medial corner repair. It was not that the patient did not come back. And I have seen it at least for 9-10 years.
Sir, there is a cadaveric study recently actually published that they have seen is they have cut the ACL isolated in cadaver. There is no anterior instability.
Right.
But they have to cut, now they have come up with a new ligament, anterolateral ligament.
That's right.
So if you cut the anterolateral ligament along with, only then there is a drought. I think the ligaments are very important.
Right.
It's not only the ACL.
Right. So but this patient did come back for many years, not just for some reason or the other, did come back for some other problem, but I had the opportunity to follow her up. Another question, I have to ask one question. That have you ever seen ligamentum petali avulsions or tears along with PCL tears? Because I'm seeing a large number.
With multiple ligament injuries, yes.
Yeah, that's something which we need to address acutely.
That's common.
That you should be aware of, that it has to be addressed acutely. It is very difficult to manage these injuries. So probably if you have acute stage 1 injury which needs to be treated, is that the ligamentum petali is shredded and repair it at that particular point rather than all the something not do it.
Yeah. Because the mode of injury is same.
Yeah.
So
same.
next question, please.
My question is to Dr. Joshi. Sir, what is your take on the ACL failures due to infection and how you tackle them?
Yeah, we have had a crop of infections recently which we had to tackle, some of our own, some from others. But I think one should be really aggressive when you're taking infected ACLs. We have found that arthroscopic debridement very often is not enough. Washouts are completely useless. I think you need to realize that unless you remove your implants, the infection is never going to go away. You cannot wish it away. And if you find that after the first arthroscopic washout, synovectomy, debridement, you are not happy, just go and open the knee and do a complete debridement, because very often I find that the pannus that is there cannot be removed arthroscopically. And I had to ask Pranjal to do some of the open work for me for all my infected ACLs. And we found that only after an complete arthrotomy could we manage these infections. But we should not sleep over infections. I think they can land up with osteomyelitis pretty early, and therefore you have to be really over aggressive when treating infected ACLs. After treating them completely, I think you can think of an ACL reconstruction maybe a year down the line, but not before that.
But usually they become stable after
Yeah,
you have
because,
debrided.
there is invariably some
so they don't
stiffness.
actually require ACL reconstruction later.
And
Another
one
thing
thing
we've
I
come
just want to clarify, just because few cases present late, not just immediately after the post-op period, they went back home uneventfully.
They
stitches
usually
are
come
removed.
late.
Yes, they comes
We
late
were
after
just
6
coming
to
to
8
that
weeks.
point.
My question, we did repeat arthroscopy to do the lavage, and we have seen that some part of the grafts has been incorporated. So at that point we remove the screws, endobutton, whatever implants are there. But should we remove the remaining graft or not?
No.
This is my question. At that moment, at 6 or 8 weeks later on.
We've done these cases very often, like these patients present late with infections. Initially, they're absolutely fine, they're doing well with their rehab, no pain. And incidentally, during the biopsy, these have turned out to be mycobacteria. So you need to be very careful while treating these patients. If it's mycobacteria, you can still preserve your ACL graft, and all you need to do is do a synovectomy, treat them on KT, and they're doing perfectly fine. There can be even atypical mycobacteria which are coming up right now. We've come across at least around 3 cases
Pranjal,
which we've
please
treated.
tell him, should you take out the graft at the time
So
of
if
debridement?
it is tuberculosis and mycobacteria, don't take out the graft.
Okay. Otherwise, routinely in septic, you should take out. This is what he
Should remove
feels.
all
Okay.
the infective tissues.
Any other question, please? Yeah, Raju has a question. Then, yeah. The same question actually. We already talked about this. You want to add something to that discussion?
I've never managed it except some of these posteriorly subluxated tibia with the anterior tibial condyle fracture. They normally are missed as no bony injury, and they are referred to me as a PCL deficient knee, and they have a fixed posterior, but on the X-ray and CT scan you can see there is an anterior condylar fracture. In some of them I've tried to pull the tibia anteriorly, very difficult because 6-9 months later I have even put 90-90 traction to get the tibia back in place. It doesn't come. In patient done open release back of the, I did the open release, and at the same time I did a PCL reconstruction, at the same time I did anterior tibial condyle building up, but the patient has 0 to 90 degree movement. There is a price to pay for this. Although the knee has come back to normal position, but stiffness is a big issue in that patient. That's only
Dr.
one-
Pranjal, you
one
want to
I've
add
done.
something?
Yeah, possibly you need a posterior capsular extension. They have flexion posterior back. So maybe you can take entire posteriorly, right from medial to lateral, and you can put in examine the patient intraoperatively. If they get full extension and there is no posterior sag, leave it as that, and then you can go ahead with rehabilitation, or else put them on an external fixator which can help it distract and then gradually extend.
There was one last question.
In context of infection or either sterile synovial fistulas, what is the referendum from the panel regarding usage of non-absorbable suture or graft preparation material like Ethibond, orthocord or fiber wire?
You mean intra-articular?
Preparation of
Should we be in non-absorbable sutures and materials or not? That's his question.
Yeah, so non-absorbable suture usually doesn't remain inside the joint. It's right there in the tunnel, like tunnel basically. Sometimes I used to use Vicryl to, put all the strands together. And I have had probably 1 out of 100 cases where there was a effusion post-operatively, which I thought it is infection. Then I went and read the Vicryl allergy is quite common.
ऑब्जॉर्वेबल सूचना करना चाहिए या नहीं करना चाहिए? तो करना चाहिए.
Yeah, reinforcing the ground with it in. And somehow it doesn't be very conservative in that much amount of non-absorbable material intra-articular.
Even the biodegradable is same material as
Biodegradable gives more reaction and more fibers than the non. Half an hour, exactly after half an hour.
Thank you.
Back to the lunch. The first lecture is by Dr. Raju Esuran. Now we are talking about the patellar instability. Dr. Raju.
Good afternoon, everybody. I guess we've all had a good lunch and we are all feeling pretty sleepy. Unfortunately, this topic might further accentuate that feeling, but please try to pay some attention to this because clinical examination of the patellofemoral joint is different from mainstream knee joint examination. And let's try to go into detail of what all we like to see when we get a patient with patellofemoral problem. The usual things that we always analyze are gait, examination of the patient in the standing, in the sitting, and the supine position. Also, in the case of the patellofemoral joint, examination in the prone position. But what we sometimes miss is examination of the patient's core, examination for muscle tightness, examination for laxity, and looking at the foot, looking at various possible syndromic associations that may or may not be present. So let's start by the gait. In the gait analysis, we broadly have a look at how the patella is placed, what is the position of the patella, is it a patella alta or it's a patella baja, how is the tibial tubercle located, what is the foot progression angle, which is a concept which most pediatric orthopedic surgeons are taught, and what is the patellar height. Generally, we are looking for any out-toeing of the patella, any in-toeing of the patella, or a high riding or a low riding patella. In the standing position, a gross look at the alignment of the limb, fair assessment of tibial torsion, genu recurvatum, etc. can be made. So this is how we generally look at the patient when he comes to us. This boy has bilateral patellar instability. He has a valgus alignment. He has a slight element of recurvatum as well. The patella seems to be positioned in a outward manner. There's an out-toeing of the patella. The height seems to be normal. So a better indicator of height can be seen when the patient is in the sitting position. So in the sitting position, one can have a measure of the patellar height. One can look at the J sign, which tells us about the tracking of the patella, and one can have a look at what is known as the thigh foot angle. So generally, when we examine the patient in the sitting position, if the patella is in the normal height, it will face forwards. A high riding patella or a patella alta will tend to look towards the roof, and a low patella or a patella baja will tend to look towards the floor. So that is a gross assessment of how the patella looks like when the patient is seated, and this person has a normal patellar tracking. Generally, when the patient is flexing and extending the knee, the patella should have a single movement up and down. And looking down, one can have an assessment of the thigh foot angle. In people who have an out-toeing of the knee, the foot will face almost in this direction, and similarly an in-toeing, the foot may have axis in this direction. This is assessed when you look at the patient from the top. So this is an example of a positive J sign. So here if you see that when the patient extends her knee, the patella not only goes up, but it also goes out as well. So a positive J sign is an indicator that there is something wrong with the tracking of the patella. the patient generally with a positive J sign tends to have a trochlear dysplasia, element of trochlear dysplasia combined with medial insufficiency. Then comes the examination in the supine position. One can choose to look at the Q angle, though with imaging, as Dr. Amit will speak in his talk, the value of Q angle assessed clinically is now not very important. One has to palpate for multiple areas of tenderness, assess for the patellar movement, that is a passive patellar glide at 0 and 30 degrees of flexion. The classical patellar apprehension test, which is graded as, sometimes you may have a patient who is so apprehensive that when you are trying to touch his patella, he will wince and he will not allow you to touch it. There is something called the modified apprehension test as well, which is said to be specific for the medial patellofemoral ligament, and assessment of patellar tilt and the range of motion. So again, examination is generally done with the knee in 30 degrees of flexion. It is very useful to keep the patient's thigh on your own so that the patient feels a little relaxed and doesn't contract the hamstrings and the quadriceps. Otherwise, you can also use a small roll towel for this purpose. When you are examining for tenderness, the patella must be pulled towards that side so that you are able to specifically examine that particular structure for tenderness. Shifting the patella to and fro, you can also palpate the undersurface of the patellar cartilage for tenderness. You can palpate the trochlea for tenderness. And you can feel the fibular head, which is located somewhere over here. And it is said that if you shift the patella in the direction of the fibular head, this is the modified apprehension test, it is strongly positive for MPFL insufficiency. This is something known as a moving apprehension test, when a slight lateral force is given to the patella and the knee is taken through its range of motion. So patients who may not have a very strongly positive apprehension test in the static position may have a positive apprehension test when the knee is taken through a cycle of flexion and extension. So these are subtle ways of detecting patellar apprehension. Another thing which we are very fond of is that we almost always think that all patellar problems are due to lateral tightness, and we are very fond of doing lateral releases. But unless the patient has a lateral tightness documented by the lift-off test, either in the OPD or under general anesthesia, one should hesitate from doing a lateral release or a lateral release or patellar instability. Essentially, what it means that you can hold the lateral border of the patella and almost lift it up to the horizontal. Sometimes you can even lift it above the horizontal in certain instances. So if you are able to do that, then it means that the patellar, it means that the lateral retinaculum is not tight. And similarly, when you are examining for medial sided tenderness, the patella should be translated a little medially so that you are able to palpate along the course of the MPFL and see if there is tightness there. A patient with the acute dislocation of patella will actually come to you in the spontaneously reduced position, and the only thing positive that you may find in your examination is tenderness along the course of the medial patellofemoral ligament. So these are of course examples of gross instabilities. These are I guess rarely missed, and probably they should not be missed. Gentle lateral pull on the patella, almost dislocating the patella under general anesthesia. So these are all examples of medial insufficiency, and these are things which we can very easily elicit on our clinical examination. In the prone position, one should look for hip anteversion, quadriceps tightness by the Ellis test, and the prone thigh-foot angle. So there's a simple test for rectus femoris tightness. If you are able to fully flex the knee without the hip lifting off from the couch, that is the Ellis test, this means that the rectus femoris is not tight. And sometimes when you have patients with unexplained anterior knee pain, they may have a tight rectus femoris, and this contributes to patellofemoral pain. So that is one test that must be done. The another test is the prone internal rotation and the external rotation test. Generally, the hip anteversion has a wide range. 15 degrees plus minus 10 degrees is said to be the normal values. So if the patient has excessive femoral anteversion, that again will load the patellofemoral joint. It can be easily tested clinically by either the Craig's test, which is a little difficult to do. But if the discrepancy between internal and external rotation of the hip exceeds 25 degrees, with internal rotation being more than the external rotation, then it is a clear-cut case of femoral anteversion, excessive femoral anteversion, which must be corroborated in the CT scan by the radiologist. Then coming to some tests which we don't look at when we see patients with unexplained anterior knee pain, the core comprises of a group of muscles which are close to the midline of the body. They, in the upper part, are the rhomboids, the interscalene muscles, the paraspinal muscles, and the gluteal muscles. So one simple test of assessing core strength is known as the step down test. In this particular test, the patient stands on a 14-inch or an 18-inch stool, and if you notice, as he climbs down, his hip on this side collapses into internal rotation and adduction. So this person has a poor gluteal muscle control, and that is sometimes responsible for anterior knee pain. If you have a patient with unexplained anterior knee pain and nothing else is positive, maybe the step down test is positive. On the left side, he has collapsing femur in internal rotation and adduction. Trendelenburg test is a good test for demonstrating gluteal control, but one step further is unsupported squat, a half squat done on the same side. If the patient has strong glutei, he will be able to do it. If he has a weak gluteal muscle, he will simply not be able to do it. He will just do it for maybe 5-10 degrees, and then he will refrain from doing it any further. Again, in this particular test, you note the position of the thigh. The thigh will again collapse into internal rotation and adduction if the glutei are weak. Pelvic bridging is another very important test for core control. The patient should be able to have the trunk, hip and the thigh all in the straight line and should be able to hold this position if he has a strong core. And then most people with a strong core are also able to extend their knee and keep it parallel to the torso and the rest of the body. So these tests, if they are negative, it means that the patient needs to work apart from patellofemoral exercises also on core strength as well, and maybe that sometimes goes the extra step in taking care of their anterior knee pain. Muscle tightness, Ellis test I have already alluded to. We all know how we check for hamstring tightness, that is just by bending forward. Ober test is another test which must be performed. Of course, these days it is not very common to get post-polio residual paralysis, but all of us have learned how to do the Ober's test on PPRP patients. And sometimes, especially in runners, they may have a very tight iliotibial band, and they can actually present more commonly with lateral-sided knee pain, but less commonly with anterior knee pain as well. So this is the classical Ober's test in which the limb should fall down below. If the limb is held in abduction, then it's an Ober positive and you should work on the lateral side. Laxity, of course, we always check for it when we are doing our shoulder instabilities, and similarly for patellofemoral instability also the Beaton score must be done. Looking at the foot position, I've already alluded to these two conditions, hindfoot valgus and forefoot pronation, are known to precipitate the anterior knee pain. The importance of identifying all these syndromic associations is that we needn't know each and everything about all these syndromes. But if you see a child or an adolescent with patellofemoral problems, nail patella syndrome can be very easily diagnosed by getting a pelvis X-ray. Iliac horns will be present. Down syndrome is not hard. It's not hard to miss, and it's important to send a referral to a pediatric colleague or to a geneticist so that further things can be evaluated for these particular patients. So that's a kind of a broad overview of how you would examine, or rather how I look at patellofemoral joint. So I'd just like to leave you with this message that whenever you have a patient with this problem, look beyond the patella. Sometimes the cause may lie elsewhere. Thank you so much for your kind attention.
Session, and I'll try to keep the theory as minimum as possible. Please bear with me. So a couple of days back, one of my junior resident called me, and he was telling me about one patient, which was a 14-year-old female. She had tripped while dancing, and she couldn't get up on her own, and the examination didn't reveal much except the knee was swollen like a big balloon. So this was the history which I was conveyed on phone. So what comes to my mind when such a history is given to me? Could be a ACL tear, it could be a meniscal tear, maybe a fracture. Then I was just thinking about it, and I suddenly came to know it was a patellar dislocation. So guys, whenever you see a swollen knee in acute injury, particularly in a young hyperlex female with valgus knees, and maybe the opposite history, knee dislocation is there, always think about dislocation of patella. Patellar dislocation is common, and it is the second most common cause of hemarthrosis after ACL tear. It generally happens in the younger age group, and the incidence in the younger age group increases by 6-fold as compared to the in general incidence of the dislocation of patella. The patellar dislocation occurs in two types of patients. In one patient, the injury is a severe injury and leads to the dislocation, and other, in the predisposed patients, a relatively less severe injury. Diagnosis is not a problem. It's mainly a clinical diagnosis. It's based on sequence of events and the findings. There is nothing much in examination in acutely swollen knee other than you might find tenderness on the medial side. And if you're lucky enough, you can find the defect also in the medial retinaculum. There is a definite role of arthrocentesis. We have discussed it earlier also. In the tense knee, I would always like to do the arthrocentesis. I would like to do the tap with at least a 16 gauge needle or a metallic bore cannula. And never throw the aspirate in a dustbin. Just examine, put it in kidney tray and look for fat globules. It may be an indirect evidence of a underlying osteochondral fracture also. And the other idea about the arthrocentesis is helps in decompressing the joint and helps in the quadriceps rehabilitation. The younger age group, they have a little different clinical presentation because of relatively atraumatic dislocation, and effusion may or may not be there, and very less soft tissue damage. Such patients generally have any underlying anatomical variations, which Dr. Raju has already spoken about. Look for ligament laxity. The thumb will be able to touch the forearm. The first MCP joint will be parallel to the forearm, and elbow hyperextension, knee hyperextension. Radiological evaluation is generally done to look the position of the patella and to look for the osteochondral fracture, not to diagnose the patellar dislocation. Most commonly AP view is done, lateral view is done to look for any patella aorta. Merchant view should be done, not the skyline view. This was the patient with patellar dislocation in which the skyline view is showing a relatively normal positioned patella, and following this a merchant view was done which showed a subluxated patella. Actually what happens is in skyline view the patella reduces in the joint space, and the merchant view which is done in relatively less flexion like 30 to 45 degrees knee flexion, a subluxated patella can be really looked on. However, the osteochondral fractures may be missed in 30 to 40% of the initial radiographs which have been proven in the surgical and the MRI studies. So, MRI should be done a little sooner than later, maybe after arthrocentesis in a week or 2 weeks' time. Other findings on the MRI may be the bruise on the medial patellar facet, the lateral femoral condyle, osteochondral fractures to really assess the type of the MPFL tear and the location, and look for other associated injuries so you can plan the procedure. Management, either conservative or operative. So it's a big controversial topic whether to go for the conservative management or the operative management. Let's have a look at it. Let's see the concerns of the non-operative management. What type of, how long the immobilization should be done and with what the immobilization should be done. Whether it should be cast, brace or the splint. After the immobilization, how to rehabilitate the patient. What if the symptoms persist? What are the redislocation risks? And what the literature has to say about it. So immobilization, the main idea about the immobilization after reducing the patella is to alleviate the pain, to provide the comfort. It is not to prevent the recurrence. Immobilization, maybe for how long, will not prevent recurrence. If it has to dislocate, it will dislocate. And the recent studies have shown immobilization should not be more than a week or maximum 7-8 days period. Immediate weight bearing as tolerated with brace. Early mobilization is important in maintaining the articular cartilage health. Early mobilization doesn't prevent the healing of tissues. It has nothing to do with that. There are little studies which have compared the cast, splint and brace for the dislocation of patella, but nothing conclusive. So at the last, the cast, splint and brace all are same. So be choosy about your patients and prescribe anything you like. Rehabilitation, closed chain exercises are preferred upon open chain exercises. Also with the strengthening of the quadriceps, the strengthening of the gluteal muscle is also important. The gluteal muscles help in promote the external rotation. Otherwise, the limb will go into internal rotation and extension, and thereby relatively increasing the Q angle. So these are the few examples of the closed chain exercise when the patient is supine, and the below ones are the patient in the standing position. Slowly as the rehabilitation progresses, half squats and the full squat, single leg squat, and extensive raises can be added onto it. So what if the symptoms persist with conservative management? There might be an intra-articular loose body. So remember this, and once it's diagnosed, then arthroscopy is the treatment for the removal of the loose body. Risk factors for the reed dislocation, we'll again learn about it in the subsequent lectures. Now the concerns about the surgical management are, one is the MPFL tear, and second is the osteochondral fracture. Osteochondral fracture per se as of now is the only absolute indication for surgery, and as a rule of thumb, it's very small, remove it. If it's large, fix it, no matter how you fix it. But remember to look for it, because earlier also I've told, like in 30 to 40% of the initial radiographs, the osteochondral fractures are missed. As of now, the indications of surgery mainly is the osteochondral fracture and the tear in the medial structures in a very high demand patient. Some authors also believe the laterally sublux patella on the merchant view is also an indication in patients, and a severe disruption of the medial structures, MPFL, VMO, and adductor mechanism. What has the literature to say about it? A recently done Cochrane review and the meta-analysis didn't prove any major advantage of the surgical management over the conservative, but all those studies which were done were mainly based on the non-randomized retrospective studies, which were not comparable groups. The recent studies have come up with the good surgical results in respect to the dislocation rates. So this was the study which recommended the initial conservative management, arthroscopy, and wherever osteochondral fractures were present, and at the end both were the same, conservative and operative. Another study in 2009 done in Finland, they showed less dislocation rates in the operated group. Early stabilization groups, the rates of dislocation were low, but at the end of the 7 years follow-up, they didn't find much difference in the overall functional results. So at the end, I would conclude, like, no clear evidence in the literature that the surgical treatment is superior to non-surgical treatment, even though the recurrence rate is lower in the surgical group. To conclude, non-operative treatment is definite for the first-time dislocator. However, we should prognosticate. What happens is, if I tell a patient, like, you don't need a surgery, and I put him on conservative management, and maybe 2 or 3 months down the line, he dislocates again. He goes to another person, and he tells, देखो पहले डॉक्टर ने कंजर्वेटिव ट्रीटमेंट किया था, 1 हफ्ते के लिए प्लास्टर लगाया था, इसलिए फिर से निकल गया. We need to tell our patients, like, it might get dislocated in 40% of the cases, and this is the treatment, nothing else will go wrong, and even if it dislocates, there are better results with the reconstructive treatment. And 60% of these patients will get rid of the unnecessary surgery, which might be done earlier. So at the end, take-home message, think of spontaneously reduced patellar dislocation in acutely injured knee. Look for bony fragment. Think if the conservative management is not working, there might be osteochondral fracture. Merchant view should be preferred over skyline view. MRI should be done sooner than later. Immobilization for very short period just for the pain relief. Putting a cast or making the patient non-weight bearing has no effect on the healing of the tissues and the recurrence rate. And early stabilization has no role as on December 2013, but the surgeons are really working hard to maintain the surgical results. Thank you.
And I'm sure there's going to be a lot of overlap in various talks. So what I'll do is, as Manish has already spoken on acute instability, so my job is to investigate what investigations to do in patellar instability and when to operate. So I'll just rush through the slides on acute instability and focus more on chronic instability. So etiology of PF instability, as has been already spoken about, is multifactorial, and the role of imaging is to identify those patients in whom there is an anatomic abnormality so that we can correct that anatomic abnormality. So why investigating acute patellar dislocation has been already discussed. We want to pick up osteochondral fractures, identify patients with high risk of redislocation, and then maybe confirm diagnosis in doubtful cases. So incidence of osteochondral lesion is quite high than we realize, and large osteochondral defects are an indication for operative fixation. Like I'll take you through this case, and a case of supposedly soft tissue injury was given a cast in this position, slab in this position, and patient comes back after 6 months with this picture. So meaning thereby it's not easy, it's not hard to miss osteochondral fractures, although I would say to miss this bigger fragment is not on. So radiographs should be done AP, lateral and skyline or Merchant's view. Merchant's view is a better view to look at the patellofemoral joint. And what are the indications of getting an MRI done in acute dislocation? It's not indicated in all the patients. So if you suspect, if you have a patient with large effusion, there is locking in the knee, there is aspirate which shows fat globules, and patient is of high performance. And if you suspect concomitant injuries like ACL or other injuries, then please get an MRI done, and in case of doubtful diagnosis. Now, when to operate, this has been discussed, so I'll not go into detail. The only point that I want to highlight here is, in case of first-time dislocator, you find that there are anatomic risk factors for redislocation, which de jure calls it as objective patellar instability. Those are the cases which may be better candidates for surgical stabilization in the first instance itself. Now, coming to chronic instability, the key to a successful treatment of recurrent dislocations is to treat the anatomic abnormality. And the role of imaging is to look for these abnormalities. Now, what imaging techniques do we have? We have conventional X-rays, which include AP, lateral and axial views. We have CT scan, MRI, and in some cases, bone scans also play a role. Now, looking at various causes of patellar instability, you have to have something in your mind before you order an investigation. What are you trying to look at? So these are the broad causes of patellar instability, and your investigation should be directed to identifying one of these causes. So, and it's not uncommon to have more than one factor in a given patient, because as we know, form follows the function. So in case there is an instability, the form also starts getting abnormal. So coming to trochlear dysplasia, these are two things that we need to look at, the sulcus angle and the crossing sign. Although there are a lot of other measurements have been described in literature, but I'll not talk about that because they only confuse you rather than proving to be of any help. Now, sulcus angle is the angle which dictates which tells us about the depth of the trochlear groove. So normal angle is supposed to be less than 140 degrees. One critical point in evaluating the sulcus angle is that the X-ray should be done at about 30 degrees, because as this diagram is showing that the trochlear groove deepens as it is as you go distally. So in case you take the knee into 40 or 50 degrees of knee flexion and take an X-ray, the value that you get might be erroneous. And the second thing that you try to see in a lateral film is the crossing sign, which was described by de jure. So what happens is, in a dysplastic trochlea, normal trochlear depth is like this. It follows the femoral condyles and never crosses the femoral condyle. In a dysplastic trochlea, meaning thereby the shallow trochlea, the line of trochlea would cross either of the femoral condyles, meaning thereby that there is some trochlear dysplasia. But to evaluate trochlear dysplasia, we need to have a true lateral view of the knee. And it's not very easy to get true lateral view, and you'll have to struggle a lot during your initial few cases to get this X-ray done. But ultimately, once you get it done, you'll know, okay, what is the position in which you should be doing your X-rays. So to evaluate lateral film, these areas of femoral condyle, they should be overlapping. And distal, it's not possible to overlap the distal condyles because the anatomy of medial and lateral is different, but these areas must be overlapping. Now, the influence of rotation on the reliability of lateral knee radiographs has been critically analyzed in various studies. So, rotation is very important. Slight rotation deviation leads to false positive or false negative outcomes while evaluating trochlear dysplasia. Like this is a true lateral X-ray, and if you externally rotate or internally rotate, then it may be falsely positive or falsely negative. Another example of this slide has been taken from de jure's presentation. So, it's a control group where this is the depth of the trochlear groove, and this is the crossing sign. So So based on the lateral films, the classification of trochlear dysplasia is done into 4 types, type A, B, C, and D. I'll not go into detail, but lateral film evaluation is a must in case you are suspecting any trochlear dysplasia. Now the second cause is patella alta, and you must suspect patella alta in case you have a case of patellar dislocation in an adolescent patient. So there are various indicators, they have been described, but it is this ratio which is very important. That is, you measure the articular surface of the patella from this and then make a ratio. So this is known as AT and PA distance. In case it is more than 1.2, that means there is patella alta. Now coming to the third important cause is MPFL or insufficiency and lateral tightness. So how do you evaluate for the lateral tilt of the patella? It is by taking this angle on a axial view, and you measure this angle of the lateral tilt. In case this is negative, that means there is abnormal middle side looseness and abnormally tight lateral structures. The fourth important cause of patellar instability is distal malalignment. And how do you check for that? You either have to get a CT scan done or an MRI, and you have to measure the lateral thrust of the quadriceps onto this thing, and then measure TT and TG distance. So in case it is more than 20 millimeters, it is said to be abnormal, and you have to tackle this in that fashion. So that's how you measure TT and TG distance. Now the fifth important cause of patellar instability is coronal malalignment of the lower limb and rotational deformity of the lower extremity, and it could be a genu valgum, thereby increasing the Q angle and hence chances of instability. And there could be excessive femoral anteversion, which Raju has spoken about. So both these conditions can be assessed either on a long film or a CT scan. So if you suspect excessive anteversion of the femur, you have to get a CT scan and request your radiologist to give exact anteversion that the patient might be having. Coming to treatment, how to decide and when to operate. So the treatment for patellofemoral instability is a la carte. No single treatment can be said to be true for every patient. And one must focus on pathoanatomy, which the investigations are telling you. And you may need multiple procedures for in a given patient. The debate is no longer distal versus proximal. The concept has changed a great deal in the last decade or so on PFJ instability. Isolated lateral release is to be condemned, and emphasis is on MPFL and TT-based procedures, and some patients might require trochleoplasty. I'll just take two of your minutes more on that, how to decide which procedure to perform in a particular procedure. So in a trochlear dysplasia, the answer is trochleoplasty. In case of patella alta, the answer is distalization of tibial tuberosity. In case of MPFL insufficiency and lateral tightness, the answer is MPFL reconstruction plus minus lateral release. In case there is distal malalignment, obviously you have to go for TT transfer, which could either be medialization or medialization plus anteriorization. In case you have coronal malalignment of this distal limb or rotational malalignment, then you have to go for femoral osteotomy. So the take-home message would be in acute dislocation, investigations are X-rays, which should include AP, strict lateral and axial films. And treatment primarily is conservative, except for if you have osteochondral fractures or patients have anatomic abnormalities in which you would like to correct them before the patient recurs. In case of recurrent instability, investigations include X-rays, AP, strict lateral, and Merchant's view. You must get a scanogram done, and CT scan in case you suspect abnormal Q angle or there are other suspicions. In a recurrent instability, I think CT scan is a must, and you should measure TT and TG distance. MRI gives additional information, but it is not a must, and treatment remains to be individualized towards pathoanatomy. Thank you very much.